Welcome to the Medical Collective, your go-to podcast where medicine meets real life. I'm Dr. Keisha Davis, a pathologist, personal trainer, and your host. I will be joined by a vibrant team of doctors who are not just healthcare professionals, but artists, fitness enthusiasts, and advocates for change. Each episode, we dive deep into the world of medicine, from untold stories of the healthcare industry to the latest in medical advancements. We're here to bring your insights, answer your burning questions, and explore the art and science of healing. So let's get started and step into the world of the Medical Collective. Hello, and welcome to another episode of the Medical Collective with your host, podcaster and pathologist, Dr. Keisha Davis. I hope you guys are doing well. I've been doing good. Cannot complain. A lot has been going on. I just celebrated an amazing birthday. I'm another decade older, everybody. I am. This episode, I was surprised that I thought about, and I'm just wondering myself, why did I wait so long to have this conversation? And it's about why doctors can disagree and both be right. I hear a lot of patients have these conversations, and now I'm going to explain it to you all. One of the most confusing experiences as a patient is hearing two doctors look at the same information and give different recommendations, right? One says surgery, the other one says, let's wait. One says, let's do a biopsy. The other says, let's repeat the imaging. One says medication, and another says, let's watch and see. So who's right? Sometimes actually both of them. And that's what I want to talk about today. One of the biggest misconceptions about medicine is that if two doctors disagree, one must be wrong. Or they missed it, as we've talked about before. Right? But medicine is not math. I love math, but it is not math. It's actually an art and a science. It's science being applied to human beings. And human beings, we have to admit, we are complicated. And I want to talk to you about why doctors can disagree and we both can be right. Why second opinions can be valuable, very valuable, and why disagreement does not automatically mean incompetence. Thoughtful disagreement is actually one of the best ways medicine protects patients. You know that? And if you listen to some of my previous episodes, like why some cancers are missed or what doctors really mean by normal results, this is another episode in the same theme, in the same thread of the conversation, helping people understand how medicine actually works. We can talk about a diagnoses, but these are the conversations where context matters. Two doctors can look at the same patient and both be right. Let's get into it. First of all, the reason why is there can be different information. Before we talk about disagreement, we have to recognize something really important. Doctors often do not have the same information. And that alone can create different recommendations. A primary care physician, for instance, they have followed you for years, maybe 10 years. They know your history. They know your family. They know what kind of ice cream you like if you like it. They know your personality. They know what happened to you 5 years ago and even 6 months ago. A specialist, on the other hand, or an ER doctor, is seeing you for a moment in time. An emergency medicine physician, as I just mentioned, may only see you for 20 minutes. A surgeon may focus on one specific problem. A hospitalist may know you from that hospitalization. Everybody is looking at the same patient with a different lens. So they're not necessarily getting the same information. For example, let's go to the ER. Been there, done that, right? And I've actually even had chest pain. Had an episode on that. You arrive to the ER with chest pain. The emergency physician is supposed to make sure you're not having a heart attack, right? They're there to make sure the chest pain is cardiac related, or is it anxiety, or is it skeletal muscle? A primary care physician may know that you've had anxiety related chest pain for 15 years, but this is not the first time. Neither physician is wrong. Neither physician. The ER doctor knows they have to rule out cardiac pain. Your family medicine physician has known you and has already ruled that out. and sees the signs and symptoms. So they're working with what they have. They are. An oncologist may focus on treatment options. A surgeon may focus on if you can get operated on. And me, I'm focusing on a diagnosis and what information I'm given. A lot of the times when I get a specimen, a slide, I have to go back and find out as much information as I can. And I still may not know as much as a primary care physician. So we have different vantage points, and it creates different recommendations because of that. And it's not disagreement. It's just the perspective. Now, let's talk about this, different interpretations, because I think that we may need to dive deeper into why doctors can disagree because they're looking at different pieces of the puzzle. And I remember the days that I used to sit at that table with my friends and do puzzles. And that's what it is. Figuring out what's going on with you is a puzzle. And that's where the second part is different interpretations. Different interpretations. So when doctors have the same information, but they have a different interpretation of the same information. Some areas of medicine require interpretations. Many patients assume that your diagnosis is either right or wrong, right? Black or white. Nothing in medicine is black or white. Positive or negative, like some of the lab tests we have. Cancer or not cancer. But there's a spectrum to many diagnoses. This is where we have inter-observer variability, meaning because there's a spectrum, and even in the textbooks, not every disease has specific signs and symptoms. Sometimes there's overlap. And that's where you have to figure out where that overlap is and where that patient diagnosis goes. Meaning, for instance, you have two trained physicians. They're looking at the same findings in pathology, in radiology, in dermatology for sure, with all of the rashes they see. They may go and show their colleague. You may see somebody else come in the room and they're like, hey, what do you think about this rash? And the other doctor may say something totally different based on also their experience. You know, when we go to residency, a lot of us go to different residencies. Were we in small town? Were we in a big academic hospital? Do we move around? Were we on the East Coast? Were we overseas? That can really affect how we interpret certain situations. And I see this all the time as a pathologist. For instance, the prostate. So everybody knows I'm a pathologist, and everybody knows I'm anatomic and clinical certified. So I have 2 of those board certifications, and then I have a third one, cytopathology. Now, there are some pathologists that are very specialized. They do a fellowship in GU, and they're able to look at prostates at a more intricate level than a general pathologist, what we call ourselves. I go into a hospital, I can look about anything, but if I have a concern, I'm going to send it off to a specialist or show a friend, a colleague. And a GU pathologist will look at a prostate and may catch a size of a prostate cancer and catch that extra millimeter that a general pathologist may not do. Both of them are trained. Both are competent. But one has a highly specialized expertise. But in the real world, not every biopsy can go to the expert. They can't, they just would not have the time to look at all of that. And that's where we have general doctors, general pathologists. But this is why we have second opinions. Not because somebody was incompetent, but because expertise matters. And when it comes to cancer diagnosis, we always have 2 eyes. We're required, especially with breast and prostate, to show our case to a second pathologist and get it reviewed. And there is a published article showing that second opinion studies have found clinical meaningful diagnostic changes in about 5 to 15% of these reviewed cases. So changes have been made to the diagnoses based on this second review. So it's important. And the rates can even be higher if it's a melanoma, melanocytic lesion, a lymphoma, soft tissue tumors, and other things. So same thing happens in radiology. 2 radiologists may differ on whether a lung nodule is suspicious or not. 2 dermatopathologists can differ on whether a lesion is atypical, a pigmented lesion on your body, or is it concerning for melanoma in situ. And that's not medicine failing. That's medicine dealing with complexity. Not every diagnosis is black or white, and some of them live in this gray zone. And I think that's when disagreement happens, because medicine requires interpretation. Everybody's brain, we're wired differently. We interpret things differently. It's just life. So the next type of disagreement is a diagnosis disagreement versus a treatment disagreement. And before I go any further with this, there's another distinction that patients should understand. Diagnostic disagreements is different from a treatment. Why? Let me explain. Diagnostic disagreement, what is it? This is my diagnosis, my interpretation, what I just explained before, may be slightly different than someone else, or clinical diagnosis. Treatment disagreement is we all agree on the diagnosis, but how should we treat this patient? There can be a disagreement on that. There's complexity. So again, one pathologist may call a pap smear atypical, another may call it dysplastic, and another may classify it differently after additional testing, which is important for testing and showing around as well. That's a diagnostic discussion. But let's say that everybody agrees it's cancer, right? So now, again, the conversation goes, should we operate first? Should we do chemo? Should we watch it? Should we do radiation? And then it depends on what the patient says. If the patient says, I don't want any of that, then that already lets you know where you're going to go. That's a treatment discussion. Many people lump those together, and I see that a lot, that there was a disagreement. Was it a diagnostic disagreement or was it a treatment disagreement? Two different processes. Next, where the disagreement, it can go into the diagnoses of the differential. So how doctors actually think about this, the differential diagnoses. One thing patients rarely get to see is what physicians are doing behind the scenes. You know, when sometimes some of the doctors will have a piece of paper or they'll have a board in their office and you'll see them showing you all the things, explaining it. Well, we use that board also sometimes in our mind when we're trying to do a differential diagnosis for you. And when I was in training, we had an algorithm for that, and it was DABDA. And it explained a lot. Is this a degenerative process? Is this an autoimmune process? Is it neoplastic? Is it infectious? Is it idiopathic, meaning there is no known cause? Is it genetic? Is it medication related? And that's how they try to go down and figure out one by one, you have these signs and symptoms, what's causing it? Well, let me use fatigue for an example. You come into a clinic with fatigue. One physician thinks it's a woman. Let's add some color to it, because then when we get into sometimes our biases based on your clinical presentation, we start to skew our vision one way or the other. So you come into the clinic with fatigue. One physician thinks it's iron deficiency anemia. Another thinks, oh, they probably have sleep apnea or not getting sleep at night. Another thinks maybe it's depression or cancer. Same symptom, fatigue. Different possibilities for the diagnosis. Very different possibilities, should I say. And that's why it takes sometimes, again, I mentioned multiple visits to have that conversation when it's something that's chronic and ongoing. Now imagine this rash. One physician says it's eczema, another says it's psoriasis. One thinks it's a fungal infection, which why sometimes when you go to derm, they'll start off with some medication or an antifungal and see if that works. And if that doesn't work, then they're like, well, maybe my diagnosis was wrong, right? Another thinks lupus, skin cancer. The point is that doctors don't begin with certainty. They begin with probabilities. And different physicians may weigh those probabilities different. And that's how we get to this differential diagnosis, or a difference of opinion. And not actually opinion, a difference of interpretation of diagnoses. So let's say that everyone agrees on the diagnosis. Disagreements can still happen. Why? Because depending on the specialty of the doctor, physicians have different risk tolerance. In medicine, it's the amount of uncertainty you're willing to accept before taking an action. So let's do a thyroid nodule. If you ever had your thyroids right here in your neck, you're starting to feel a nodule. You go to your primary care doctor, or you may go directly to an endocrinologist if you have one. And one of the doctors says, let's biopsy it now. Maybe the endocrinologist. Or another one says, let's do an ultrasound and repeat that in 6 months. Both agree on the findings. You have a thyroid nodule. But how to proceed with that nodule, wait and see versus biopsy right away versus ultrasound, depends on the risk tolerance of your doctor or even the specialty of them. The same thing happens with pulmonary nodules. When you say sometimes the doctor didn't do anything, their risk tolerance may be right now the best thing to do is wait and see. Because again, using imaging, using biopsy, that takes time and money and can also sometimes lead to more stress, unneeded stress. Prostate cancer surveillance, breast lesions. I have had many breast lesions biopsied, and I've had many just wait and see is the method that we use with ultrasound and with MRI. So it just really depends on the risk tolerance. Many medical disagreements are not about facts, they're about the risk. That's again why it's not a yes or no, black or white issue. Hello, listeners. We want to remind you that you can catch The Medical Collective on all your favorite podcast platforms. That includes Apple, Spotify, and YouTube. Be sure to hit that subscribe button so that you never miss an episode. We're also on Libsyn, and you can find us on all social media platforms as The Medical Collective. Do you have thoughts or questions? Please don't hesitate to reach out. We love hearing from you. Now let's get back to the conversation. Now, let's talk about this. As we're talking about decision and treatment pathways. Even when physicians disagree or agree, let's say they agree on the diagnosis and they agree on the risk, right? So now we've got the diagnosis, they're all agreeing on it. They're done with their differential, they agree on the risk. They may still choose different pathways to get to the same goal. Dermatology, for instance. And I love my dermatologist. By the way, I actually wanted to be a dermatologist at one point. One physician may treat and say, okay, this looks like this could be maybe a rash or something, or a bug bite. Let's treat it first and see if it goes away, and biopsy if the lesion does not improve. Another physician could say, let's biopsy right now. Neither is automatically wrong. And I think that's where sometimes as a patient, you may get confused. There's not a textbook answer on how to do this. And then let's say, for instance, a whole nother thing that complicates things is depending on the physician. If your schedule is different, you're a single mother, a single parent, or you know you're not going to be able to come back for a year, or you are a patient, it's hard to get into the office, they may decide to biopsy immediately because they know that. If you're someone that's always calling, coming in, able to come in, they're going to watch and wait with you. So it truly depends. Different clinical pathways. The same thing happens in primary care. One physician starts a conservative treatment first, another may refer you immediately. Now let's go to cancer. This is where tumor boards become important. Now, if you go to a larger medical center, and some not necessarily attached to a medical center, there are tumor boards that are happening behind the scenes. Okay, at a cancer conference, everyone may agree upon the diagnoses. This is when a pathologist, an oncologist, if it's a breast cancer, the breast surgeon, maybe even your doctor, your physician, the radiology, all of them are sitting around talking about this. So they've agreed on the diagnosis. Pathology came in, showed the diagnosis. They agree on the stage. And now here comes the discussion. This is where the nuance of an echo chamber isn't. Because an echo chamber, people assume an echo chamber is that everybody agrees on everything. In these situations, you do have to agree on the facts. And that's a problem with social media and a lot of conversations, about other things in medicine, is that people have alternative facts. And so you're starting already where they don't even believe in the diagnosis of an infection or things like that. But when you're at a cancer conference, diagnosis, pathology stage agreed upon. Now, the discussion is, Should surgery come first? Should chemo come next? Radiation first? Should we do active surveillance? All of these discussions are happening. And this is something that patients don't realize. Two patients can have identical symptoms with cancer, anything, maybe imaging findings, pathology results, and still receive different recommendations. You hear me? Two patients can have nearly identical symptoms, imaging findings, pathology results, and receive different recommendations. And why? Because medicine is not treating people. We're not treating diseases. I'm sorry, because medicine is treating people, not diseases. That's why. Age matters. How old is this patient? What are your comorbidities, meaning do you have diabetes? Do you have heart disease? What is your functional status? Are you homebound? Are you bedbound? Are you highly functioning? Are you an athlete? What is your family history? What are your patient goals? Do you have so many things going on to where you really don't have many other options? Are you 90 years old? Are you 15 years old? That's how diagnosis and treatment can differ. And it's also why when you're in these groups, you get a diagnosis and you're in these support groups and you hear somebody else and you're like, well, they have the same thing as me. Why did they have that happen and not me? It's because we treat the patient, not the disease. For instance, a healthy 45-year-old and a frail 85-year-old may receive very different recommendations for the exact same cancer. And it's not because medicine is inconsistent or the doctor got it wrong. Patients are different. And there's even more going on now with the biologics of your tumor that may lead to you having different treatment than somebody else. I hope that helps you. Now there is the reality that doctors are human beings. Trust me, we are human. I do not have a cape anywhere. If I look, I don't see a cape. I'm not a machine. I'm not an algorithm. I have training though. Doctors have expertise, experience, practice environment. We have patient populations. And we have to use all of that in every decision that we make. A physician who has seen a rare disease 10 times, they're going to recognize it immediately. But another physician may have never seen that rare disease. That doesn't mean one is smarter. It means experience matters. It also means consultation and getting recommendations from others matter. And yes, we should acknowledge that there is implicit bias. But in many situations, differences arise not because of these bad intentions, but because of differences in experience and perspective. If you're looking at a patient, are you assuming that their pain is not real? Or are you assuming that, oh, this must be what they're having when it's not the case? So, of course, yes, there are times where doctors also need to recognize that. So when should disagreement concern you? By this point, some people are wondering, I'm sure, how do I know when this disagreement is normal and when should it concern me? I'm about to tell you guys some red flags, and this is a fair question. A physician who cannot explain the reasoning. If they get defensive or they cannot explain why they're doing XYZ to you, that should be a red flag. Another one, a recommendation that does not have supported evidence. You can ask them, what is the evidence for this? Another maybe red flag, but not necessarily, because it depends on how specific your disease is and the treatment recommendations. But refusal to discuss alternatives can be a red flag. Another is dismissing concerns without evaluation. And that also brings me to something we need to recognize. Not all doctors are for every patient. You know how you meet someone and you're like, oh my gosh, I really feel that person, like we connect. If you don't have a connection with a doctor, especially when it comes to a chronic disease or a cancer, they may not be the doctor for you. Now, if it's a surgeon or somebody very specialized, that's when you might have to have a conversation with them to at least get to a point where they can do what they're supposed to do. That I agree with. But if you have a doctor that's dismissing your concerns without evaluation, that should be a red flag. Also, We talk about this if someone is practicing outside of their expertise. Okay? Now, we have generalists for a reason, yes, but they also consult physicians when it's time to. Those are the situations that I just mentioned that should deserve closer attention. But normal disagreement often looks like timing differences, right? Surveillance differences, treatment selection differences, and the procedure differences. And disagreement, again, alone is not the problem. The reasoning behind it matters. And they should be able to explain that to you. They should. Now, why does medicine intentionally create disagreement? Here's the perspective that I think most people miss. Medicine intentionally creates environments, or medicine leads to environments where disagreement happens, but it's not intentionally. Tumor boards, cancer conferences, we have disagreement. And that is actually healthy. That is healthy, productive conversations, right? If you give somebody what we call constructive criticism, same thing. That's what's happening at tumor boards, at cancer conferences, at peer reviews. Did you know even physicians within a group, they get peer reviews where they're looking at what they have done, their charts for us, our cases, and they're telling us an evaluation of us. Consensus panels is another one. Conferences that are called morbidity and mortality. When people are sick or they die, they go back in these conferences and look at what happened at all the levels of care. Multidisciplinary breast conferences do the same thing. Pathology consultations. If somebody looks at our case that we send for a consult, we're finding out, is our interpretation correct? Do we agree with them? Second opinions. These systems exist because medicine was never designed for one person to know everything. And we don't. They're designed to challenge assumptions. That's the healthy degree of dissension. They are designed to catch blind spots and to improve decision-making. People often misuse that term echo chamber. There's not an echo chamber because everyone agrees in cancer treatment or chemo or agrees in vaccinations. That's not an echo chamber because you now see there's so many more levels to it. Now that we agree that there is this cancer or this, now on how to approach it or how to even classify it, that's where the disagreements or perceptions can change. And that's fine, can differ. And I agree, medicine is not weakened by this thoughtful disagreement. It's strengthened by it. It is strengthened by it. If two thoughtful, competent physicians disagree, the question isn't always who's right. Sometimes the better question is, what is each of them seeing that the other one is not? Because disagreement doesn't always mean medicine is failing. Sometimes it means that medicine is working exactly how it was designed. I don't think it was ever intended to be practiced by one person in isolation. And that's why second opinions exist. That's why tumor boards exist. That's why peer reviews exist. And that's why thoughtful disagreement remains one of the most important safeguards in healthcare. Now, if you enjoyed this episode, I want you to go back. Go back to the episode, What Doctors Really Mean by Normal Results. That is the episode that I explored another area of medicine that is often misunderstood and why uncertainty is a normal part of good medical care. As always, everybody, thank you so much for joining another episode of the Medical Collective, diverse doctors with one mission. Until next time. Thank you for tuning in to the Medical Collective. We hope today's episode has left you with valuable insights and a new perspective on healthcare. Don't forget, follow us on social media for more updates and behind-the-scenes content. I'm Dr. Keisha Davis, and it's been a pleasure to share this time with you. Stay healthy, stay informed, and we'll see you in the next episode, where medicine continues to meet real life. Please note that the content provided in the Medical Collective podcast, including text, graphics, images, and other material, is for informational purposes only. The content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. The views and opinions expressed on this podcast are solely those of the individual authors and guests and do not represent those of the Medical Collective, its staff, and any affiliated entities. The appearance of content on the podcast does not imply an endorsement. Neither the host, Dr. Keisha Davis, the co-host, or any guest of the podcast bear responsibility for the accuracy of the content provided or the use of information received through the podcast. Reliance on any information provided by the Medical Collective podcast, its employees, writers, or guests is solely at your own risk.